So without further ado, let me start talking a bit about male sexual dysfunction, but I thought I would just show you a little bit about where I come from. I'm from North Carolina, which is on the eastern coast of the United States, from the University of North Carolina, which is the oldest public university in the States, which is nothing compared to the institutions in the UK, but we gave our first degree in 1793, and it was, or 1795 rather, and we have a long history of famous basketball players and other things. Michael Jordan, for instance, went to the University of North Carolina. This is our medical center that consists of a variety of hospitals: a memorial hospital, a children's hospital, a women's hospital, a neurosciences hospital, a cancer hospital, and I hope that someday we'll also have this hospital, which I've been pushing the dean to have, but we haven't had any major success with a men's hospital as yet. But I do have donors that come to see me that say, well, you have a women's hospital, where is the men's hospital? So hopefully someday the University of North Carolina will have the first in the United States North Carolina Men's Hospital. Still a dream. Well, basically, erectile dysfunction has been something that's been written about by philosophers and authors and others. Leo Tolstoy said that man survives earthquakes, experiences the horrors of illness and all the tortures of the soul, but the most tormenting tragedy of all time is and will be the tragedy of the bedroom. So he certainly felt that there was a huge issue in men's health with erectile dysfunction. And there's a more recent thing that says erectile dysfunction, magic can't solve all your problems. So clearly there is an issue that is even in 2011 with erectile dysfunction. And in my office, many of the patients that come to see me for erectile dysfunction have an issue with the size of their anatomy. And here's one way to treat the short penis. We don't do this particularly in North Carolina, but it's a method for enhancing the male member. Well, male sexual dysfunction comprises a number of different complaints. One is erectile dysfunction, which I'll focus most of my comments on this afternoon. Hypogonadism, Jeff Hackett will talk about. There's also Peyronie's disease, and if we have time, we'll talk a bit about premature ejaculation, because there are some new agents for premature ejaculation that are available on both sides of the Atlantic that will help the large number of men that complain of premature ejaculation. And indeed, premature ejaculation is more common than erectile dysfunction in the studies that have looked at those problems. Well, just to review very briefly the physiology of erection, it starts with a psychological or physical stimulus that then produces a release of nitric oxide from the nerve endings in the corpus cavernosum of the penis that goes through the cyclic GMP pathway and causes a relaxation of the corpus cavernosum smooth muscle, allows blood to fill the penis with influx of blood into the penis. The blood is then contained in the penis by decreasing the outflow through the veins that are just beneath the very stiff tunica alveoginia of the erectile bodies, and produces an erection that continues until the nitric oxide is no longer released, and those smooth muscles then contract, and the penis becomes flaccid again. So it's that cycle that's important in producing erections, and it's under the control of these nerves that produce nitric oxide, and those nerves can be damaged by a variety of conditions, including diabetes, vascular disease, hypercholesterolemia, and a variety of the other things that we've talked about today that influence men's health. Well, what are some of the causes of erectile dysfunction? Well, the majority of them are vascular disease by itself, or diabetes, which produces both neurologic and vascular problems that produce erectile dysfunction. We also see more and more patients that have erectile dysfunction as a result of pelvic surgery, the treatment of pelvic malignancies, prostate, colon, a variety of other malignancies that produce erectile dysfunction, again as a result of both vascular disease and nerve damage and an inability of the penis to respond to stimuli. Erectile dysfunction rises with age. It increases with aging, and complete and moderate erectile dysfunction grow the most significantly. Minimal erectile dysfunction is about the same through the ages, but you can estimate the percentage of patients in a particular decade by their percentage of erectile dysfunction. So a 70-year-old, patients in their 70s have about a 70%, patients in their 40s about a 40% prevalence of erectile dysfunction. We looked at various ethnic groups and found that there was really no difference amongst the ethnic groups as far as erectile dysfunction, so it affects every patient, every male patient that comes into your office, and indeed the female patients, because they often have a male partner that's affected by erectile difficulties. So why is it important for primary care physicians to know about erectile dysfunction? Well, clearly it's important because patients are concerned about it. You can help patients with it because there are things available we can do for erectile dysfunction in 2011, but also it can be a marker for vascular disease, and indeed you can see the prevalence of erectile dysfunction with some of the problems that men present with. Hypertension, 52% of men with erectile dysfunction, with hypertension have erectile dysfunction. Lower urinary tract symptoms are associated with erectile dysfunction independent of age. So men that come in with lower urinary tract symptoms, more than half will have erectile dysfunction, and you can see the different issues, depression being the most common one, with 90% of men with severe depression complaining of difficulties with erections. So basically erectile dysfunction, which can be defined as the inability to obtain and maintain an erection satisfactory for vaginal penetration, is a red flag for comorbidities. It can certainly adverse the sense of well-being. It can be the first symptom of underlying cardiovascular disease. And I'll show you some data that you probably that Mike Kirby already shared with you. There's an interrelationship with depression. It certainly causes personal and relationship stress. And it's certainly a motivator because patients come to your office, you can treat their erectile dysfunction. They walk away with something that can help them that evening in the bedroom. If you treat their hypertension, really they don't know that there's any difference with the pill that you've given them, other than the fact that they've had some complications or some side effects from that particular medication. Again, erectile dysfunction is a marker for vascular disease, and I won't go through this in detail because you heard this from Mike Kirby already, but clearly anything that affects the small vessels first is going to be a harbinger, a canary in the coal mine, if you will, of future vascular disease. Some data that supports that include this one. This study looked at a group of control patients, a group of patients with erectile dysfunction, and looked at endothelial-dependent vasodilation in this group of patients. And you can see that the erectile dysfunction patients were more likely to have a problem, an issue, an impairment of endothelial-dependent vasodilation than the patients in the control group. Another study, this is the prostate cancer prevention trial of more than 8,000 men, followed for almost a decade, and looked at for erectile dysfunction as a harbinger of cardiovascular events. These are the odds ratios of the men that had erectile dysfunction versus those patients that did not have erectile dysfunction as far as vascular-related events. So angina, 1.72 times greater risk, 1.5 for MI, 1.79 for stroke, 1.45 with a first cardiovascular event in men who started the study with complaints of erectile dysfunction. So if you can identify erectile dysfunction, you can often find the vascular disease that's underlying that and treat that vascular disease. And indeed, in my own clinic, I have a cardiologist that I work with, and if a man comes in with first complaints of erectile dysfunction, he hasn't had prostate cancer surgery, he doesn't have other risk factors, I send him to my colleague Eric Yang in cardiology, who does a full cardiac workup to see if we can identify vascular risk factors early on and treat those patients and perhaps decrease those cardiovascular events in their future. Psychogenic causes of erectile dysfunction are also significant. We know that any man that has erectile dysfunction, whatever the cause, has some psychological issues, but depression and some of these other things are also causes or are associated with erectile dysfunction. If you look at men with erectile dysfunction, this is a study where they looked at BPH, erectile dysfunction only, erectile dysfunction plus BPH. The percentage with depression in the ED patients were significantly higher than those in the control group. Again, depression has a significant association with erectile dysfunction. So how do we treat these patients? Once we've identified erectile dysfunction with a good history, we've done a testosterone level, we've screened them for diabetes. I see probably 5 or 6 new patients in my clinic every year that have new diagnosis of diabetes, that didn't know they had diabetes to begin with. We screen them for vascular disease, and then we want to treat them for their erectile dysfunction, and we begin with what we should be beginning with any of our patients, and that is education and quality of life, lifestyle discussions. So basically the WHO treatment guidelines suggest that the first step of treating erectile dysfunction is beginning by looking at lifestyle and psychosocial factors, prescription and non-prescription drug use, and managing those drugs, especially the antihypertensive medications, hormone replacement therapy if they're deficient in testosterone, and we'll hear more about that subsequently. Well, some years ago, it was thought that actually smoking had an advantage. This is an ad from the early 1950s. More doctors smoked Camels than any other cigarette, and certainly that was a great ad at the time. But today, we see on the Marlboro packages in many countries, smoking may reduce the blood flow and causes impotence. So that should get many of our male patients to stop smoking if they look at that on their cigarette packs. And indeed, there are a number of studies now that have documented an improvement in erectile function, even for long-term smokers. And this is one of the most recent ones. This one just came out a few months ago, where they looked at a group of male smokers enrolled in an 8-week smoking cessation program. They had transdermal patch and counseling, and they assessed them at baseline 4 weeks post-initiation of treatment, and then 4 weeks post cessation of the program. And you can see here's baseline. The successful quitters are in green, the relapsers are in red. Here's baseline, here's mid-treatment. This is only 4 weeks after treatment. The erectile function change was significantly higher in those patients that had successfully quit. And at follow-up, you can see that it's a highly statistically significant improvement in erectile function in these patients, many of whom had smoked for 10, 15, or even 20 years before ceasing smoking. And there are a number of other studies that have shown very similar kinds of data. What about weight loss? Well, weight loss is in the United States, as well as most of the rest of the world, is a real problem for us. I mean, I have patients that have had the gastric banding surgery that have eaten their way through the gastric banding surgery. I have one patient that actually had the gastric banding surgery. He was 300 pounds. A year later, he was 380 pounds. So it doesn't work in everybody, and it doesn't give them a license to begin to drink and eat more, but certainly obesity is a significant problem for erectile dysfunction. And here's a study that I think is the best one on this subject to date, where they took a group of 110 obese men and they divided them into 2 groups. One was a control group that was just sort of given general information about healthy eating. The other group was intervened and placed on diet and exercise to lose at least 10% of their total body weight. And they looked at a variety of measures after this procedure. They showed that there was a decrease in BMI of the intervention group. There was an improvement in inflammatory markers in the intervention group. They measured endothelial cell function and found an advantage in the intervention group. But one of the most important things that they found was an improvement in the International Index of Erectile Function score. Here's the intervention group, where in 2 years there was a statistically significant improvement in IIEF score compared with the non-intervention group that had no change in their IIEF scores. So losing weight and stopping smoking in this group of patients is more important than giving them a Viagra right off the bat. If you can get them to change their lifestyle, you may improve their erectile dysfunction without giving them a pill that they may have to pay for themselves. But we do have the pills, and the pills have certainly revolutionized the treatment of erectile dysfunction throughout the world. All 3 of the pills are important. They all 3 work the same way by inhibiting the phosphodiesterase type 5 inhibitor in the smooth muscles of the corpus cavernosum. And it's the PD5 enzyme that breaks down the cyclic GMP that causes relaxation of the corpus cavernosum smooth muscle. By maintaining that phosphodiesterase type 5 as inactive, and increasing the length of activity and the concentration of cyclic GMP, one prolongs and encourages the smooth muscle relaxation and improves erectile function in these patients. This is probably a little hard to see, but it encourages me to remind you that there are some new PDE5 inhibitors on the horizon. Udenafil and Avanafil are being investigated in the US and in Europe as new PDE5 inhibitors. The classic PDE5 inhibitors are here on the left, where we see that the concentrations, the time to maximum concentration, 2 hours with tadalafil, less than an hour with sildenafil and vardenafil. The two new PDE5 inhibitors really, to be honest, don't offer much different. They are different. The Tmax is about the same in both of them. The T1/2, which is highest with tadalafil, about the same with sildenafil and vardenafil, the udenafil is similar to tadalafil. The avanafil is shorter acting than any of the others, so may be quicker onset than some of the older drugs. But again, whether that's clinically important or not remains to be seen. But those drugs we'll begin to see in our pharmacies within the next 18 to 24 months. The three drugs that are available, though, at maximum dose, the outcomes, the satisfaction rates, the effectiveness rates are about 65 to 75%. And that's in studies of highly motivated, highly selected patients. In your clinical practice, you'll probably see somewhere around 60% of patients actually respond to the PDE5 inhibitors. So that leaves us an opportunity to treat some of those patients with other alternatives, other methods for treatment of their erectile dysfunction. And many patients will initially respond to Viagra or sildenafil or the other two agents, but then over time they'll lose that effectiveness. And indeed, if one looks at 1 year after initiating the PDE5 inhibitors, only about 55% of patients who are effectively treated continue on the medication. And part of that's because it doesn't work. Part of it in the US is because it's expensive and not covered by insurance. And part of it's because it's a nuisance and some patients just prefer not to do it. The other reason is side effects. And side effects are a common problem for PDE5 inhibitors, headache being the most common one. This is a study we did some years ago with sildenafil, looking at what happens if patients use the medication regularly, and if you can get them past that first dose side effect problem, do they have a continued problem with side effects? And you can see that overall side effects continue to drop as patients use the medication. Now, these patients were using sildenafil at least twice a week during this study, but you can see that as they progressed through the study, the side effects became less and less, and actually headache was the most precipitous drop of any of the side effects that patients experienced. Daily dosing is also something that's often used. We have that available in the U.S. The uptake has not been as vigorous and enthusiastic as Lilly would like, but there is an advantage of daily dosing over on-demand dosing, and we, just as with the UK, recently had approval of tadalafil for daily dosing for lower urinary tract symptoms. Probably will change the dynamic a little bit, but daily dosing also works with sildenafil. This is a study that came from Germany, where they looked at daily dosing of sildenafil, 50 milligrams a day. Here's on-demand dosing versus daily scheduled dosing, which was significantly greater. So daily dosing does have a better outcome than on-demand dosing as far as effectiveness of PDE5 inhibitor. But it doesn't always work as well as one would like. This is what all of our patients think, that they're going to have a long penis, an erection that lasts forever. But indeed, there are problems with the responsiveness to PDE5 inhibitors. And one can often salvage some of those patients by counseling them about why they might have failed. Why is their PDE5 not working? What can they do to make the PDE5 inhibitor work better? Well, one thing is that they can change PDE5 inhibitors. Some patients will respond better to one than another, so you can try some of the other agents and see if that works well for them. Understand why they think it's not working. Often patients will take a pill and look down and say, well, it's not working, what's going on? Or as I often tell my patients, you can't You can't take a Viagra and read the Wall Street Journal and expect to get an erection. You've got to have some stimulation as well to get the drug to work, and often patients forget about that. They also have to realize that it often takes 3 or 4 tries to achieve results, and then adjusting the dose to the maximum dose may also be helpful for some patients. And I think, as you'll hear in just a moment, these drugs also work best in patients who are eugonadal, patients with normal testosterone. If their testosterone is low, it's important to check that. And it sounds obvious, but I often see patients in my own clinic that are sent to me by primary care providers for failure of PDE5 inhibitors, and they've never gotten a testosterone on these people. So doing a testosterone may rescue a large number of the patients that are not responding well to PDE5 inhibitors. Well, there are second-line therapies also, second-line therapies that you can recommend in your own offices. One is a vacuum constriction device or vacuum erection device. This is available. No tests are required. It has a high success rate in motivated patients. This should be underlined, actually. The dropout rate is high for vacuum erection device. The dropout rate within 6 months is around 70% in the US. But it's certainly something that some patients respond well to, some patients enjoy, some patients get use out of, and it's a one-time investment and certainly something that patients can use. And I use it in my patients post-radical prostatectomy to maintain length. We have a rehabilitation protocol in our own unit that includes daily Cialis beginning the day after radical prostatectomy, and a vacuum erection device, not because we think the vacuum erection device will help erections, but it will help maintain the penile length during the rehabilitation program. One can also use intracavernosal injection therapy. It's been around for many years, since the days of Giles Brindley, and we still use it today in those patients that fail PDE5 inhibitors. We generally use a combination of papaverine, phentolamine, and prostaglandin E1, alprostadil, as our primary injection. The efficacy rates are up to 85%, and it works very well in those patients that fail failed PDE5 inhibitors. It works extremely well in diabetics, very well in patients that are paraplegic, that have young, vigorous vascular systems. The intracavernosal injection will work well. You can also use intraurethral alprostadil, the Muse system. It's still available, still used occasionally. We use it in the US, again, in patients that have failed PDE5 inhibitors. It does have a high dropout rate because of discomfort in the penis with Muse. But the efficacy rates in people that have failed PDE5 inhibitors is about 30 to 45%. So certainly worth a try. The third line, the final thing, is penile implants. And I know that few people in this audience probably do penile implants, but it's worth referring your patients to someone who does them if they've failed these other things. Obviously, a penile implant's not the first thing you do right out of the barrel that a patient comes in complaining of erectile dysfunction. But if they've failed the easier things and they're highly motivated and they need to have restoration of their erectile function, in fact, we feel very strongly that it's part of rehabilitation after radical pelvic surgery, that patients need to have rehabilitation. And this is one of the rehabilitation techniques that one can use. The 3-piece penile implant is the one we use most often. It's coated now with antibiotics. So the infection risk of these prosthetics is less than 1% in 2011. And the patient partner satisfaction is really quite gratifying. In fact, here's a study that was reported by Dubwalla's group from Detroit, where he looked at a group of patients that had penile implants, a group of patients on oral medication, and a group of patients on injection therapy, looking at patient satisfaction, and found that the satisfaction rate with the penile implant was highest of any of the groups. Now, that's a little bit misleading because obviously you have to be fairly motivated to have an operation for your erectile dysfunction, but it does show that the patients that had penile implants were very satisfied. Another more recent study looking at patients followed up for 12 to 48 months. In an Italian study, are you using your prosthesis? The majority were using their prosthesis 12 to 48 months later. Have they had any problems? The majority said no. Does your partner have any problems with the prosthesis? Majority said no. and has there been a change in your sex life, which is really what you want. 80% of them said indeed they did. So in the last couple of minutes, let me just move on and talk just briefly about premature ejaculation, because it's something that we now have treatment alternatives for taking care of our patients that are effective, number one, and safe. So basically, premature ejaculation is defined as very rapid ejaculation, a diminution in the IELT, which is the intravaginal ejaculatory latency time, lack of voluntary control, and then most importantly, the patients need to be distressed by their premature ejaculation. And here you can see the IELTs of patients with premature ejaculation to the left. This is the average for a group of matched controls that had normal ejaculatory control. And you can see that there is a very big difference between the premature ejaculation patients and those that had normal ejaculatory function. Indeed, if you look at the prevalence of sexual dysfunction, this is erectile dysfunction, this is premature ejaculation. It occurs at all age groups, and it's more common, actually, than erectile dysfunction, occurring in about 30% of men of all ages, and to date has not been well treated. We looked at again, a group of ethnic, divided the ethnic groups, and found that actually the African Americans and Hispanic groups were more troubled with premature ejaculation than the white Americans, but certainly it occurs across ethnic groups. The therapy has always in the past been either psychological or behavioral, but we now have medical therapy that's effective and safe, and I'll just run through this fairly quickly. Behavioral therapy, the squeeze technique is classic start-stop technique. Certainly has been something that's been recommended to patients for years and years, but really not very effective and not very well tolerated by patients. Medical therapy in the past has been the SSRI antidepressants, which have significant side effects, and treating a non-depressed patient with an SSRI antidepressant has its own difficulties. So let me just move on by this a little bit. The newer drug on the market is this drug, Duloxetine, which is available in the UK. Unfortunately, not available in the US, but this is available in the UK, and it's a very good drug. It's a non-selective serotonin reuptake inhibitor. It's rapidly acting, very short half-life. It's dosed an hour or two before intercourse, very much like a PDE5 inhibitor, and it has a significant improvement in the IELTs in the patients that have been treated. Improved control over ejaculation, an improvement in satisfaction, and an improvement in the distress associated with premature ejaculation. So it's clearly something that you can use in your office tomorrow and prescribe to your patients if they have a complaint of premature ejaculation. And here you can see the improvement comparing baseline and post-treatment with Duloxetine, which is the generic for the drug Prilogy. The other option is a topical agent that is currently under investigation and is being evaluated by the Food and Drug Administration in the U.S. And this is a metered spray of a combination of analgesics that are applied to the glans penis. They're titrated by the user, not passed to the partner because of rapid drying of the medication. And it again has a very effective treatment of those patients with significant premature ejaculation, showing an improvement, a marked improvement in IELT as early as 1 month post-initiation of treatment, and then continuing on for the longer-term follow-up out to 90 days. So with that, I will stop, and we'll have time later on to discuss some of the issues for erectile dysfunction.